Hello everyone, and welcome to this critical presentation on paracetamol toxicity, an essential topic for anyone in healthcare. I am Docsaab, and today we will dive into the nuance of paracetamol overdose, its pathophysiology, clinical manifestations, and most importantly, its management and prevention. Paracetamol or acetaminophen is a cornerstone medication globally, widely used for pain relief and fever reduction. Its accessibility as an over the counter drug often leads to a dangerous misconception that it is universally safe. This widespread availability ironically means its potential dangers are frequently underestimated by both the public and even some healthcare professionals. Tragically, paracetamol overdose is recognized as one of the leading causes of acute liver failure worldwide. Toxicity can arise either accidentally, such as through repeated supratherapeutic dosing during illness, or intentionally in cases of self harm. In the United States, paracetamol toxicity holds the grim distinction of being the primary cause of liver failure, with over 60 million Americans consuming paracetamol weekly, often unknowingly due to its presence in various combination products, especially those containing opioids and diphenhydramine. The scope of this issue is immense. Let's begin by understanding the etiology. Paracetamol is available in numerous forms, reflecting its broad application. These include immediate release and extended release formulation offered as capsules, elixirs, gels, oral, intravenous solutions, liquids, tablets, suppositories, syrups, and dissolved packs. When administered at therapeutic doses, acetaminophen maintains an excellent safety profile. For children, the recommended therapeutic dose is 10 to 15 milligrams per kilogram per dose, given every 4 to 6 hours, with a strict maximum of 80 milligrams per kilogram per day. For adults, the therapeutic range is 325 to 1000 milligrams per dose every 4 to 6 hours, not exceeding a maximum daily dose of 4 grams. However, these safe boundaries are easily breached. Toxicity is likely to develop in adults who ingest more than 12 grams over a 24-hour period, or a single dose between 7.5 to 10 grams, or any dose exceeding 350 milligrams per kilogram of body weight. For children, toxicity can occur following a single ingestion of 150 milligrams per kilogram or 200 milligrams per kilogram in otherwise healthy children aged 1 to 6. Understanding this threshold is crucial for identifying potential overdose situations. To grasp the toxicity, we must first understand normal paracetamol metabolism. At therapeutic doses, the body efficiently processes paracetamol, primarily converting into non-toxic metabolites. This occurs predominantly through phase 2 metabolism via conjunction with the sulfate and glucuronide. Only a small fraction, approximately 5%, is oxidized by the cytochrome P450 enzyme system, specifically through cytochrome P2E1 and cytochrome P3A4. This process generates a highly reactive and toxic intermediate metabolite known as N-acetyl P-benzoquinone imine, or NAPQI. Critically, under normal conditions, any NAPQI form is rapidly detoxified by the conjunction with glutathione, forming harmless cysteine and mercaptoric acid conjugates that are safely excreted. In overdose scenario, this protective mechanism is overwhelmed. The sulfate and glucuronide pathways become saturated, shunting a significantly larger proportion of paracetamol toward the cytochrome P450 system. This leads to massive surge in NAPQI production. Simultaneously, the liver stores of glutathione essential for detoxifying NAPQI become severely depleted as the demand far outstrips the rate of regeneration. Consequently, NAPQI remains in its toxic form within the liver. It then binds indiscriminately to cellular membrane molecules, initiating widespread hepatocyte damage and death. This cellular destruction ultimately culminates in acute liver necrosis. Animal studies have shown that liver toxicity typically manifests within glutathione stores are depleted to less than 70% of normal levels, highlighting the critical role of this antioxidant in protecting the liver. Several risk factors can exacerbate paracetamol toxicity. Individual variability in metabolism suggests a significant genetic component. Studies have identified various signal nucleotide polymorphisms linked to altered paracetamol metabolism and increased risk of hepatotoxicity. For example, polymorphisms in the CD44 gene have been implicated in variations in toxicity observed after paracetamol exposure. Pre-existing medical conditions also play a critical role. Individuals infected with hepatitis C virus have increased risk of acute liver injury and progression to severe liver failure following a paracetamol overdose, even in the absence of cirrhosis. Any underlying liver disease impairs the liver's ability to metabolize paracetamol effectively and to synthesize glutathione, significantly increasing the risk of toxicity. Environmental and lifestyle factors further contribute to this elevated risk. Malnutrition can deplete critical glutathione reserves, making individuals more vulnerable to NAPQI toxicity. Chronic alcohol use is particularly dangerous as it can induce CYP450 enzymes like CYP2E1, thereby increasing NAPQI production while simultaneously depleting glutathione stores. This dual effect dramatically magnifies the risk of hepatotoxicity. Co-ingestion of other substances that induce CYP450 enzymes or compete for metabolic pathways can further escalate toxicity. Concurrent illnesses can impact liver function or glutathione levels, increasing susceptibility. Finally, repeated supratherapeutic dosing, often overlooked, can lead to a gradual accumulation of NAPQI and subsequent liver damage, even if acute overdose is avoided. The clinical presentation of paracetamol overdose progresses through distinct stages, reflecting the evolving toxic effects primarily on the liver. Understanding these stages is paramount for timely recognition and intervention. Stage 1, the initial phase occurring within zero point 0.5 to 24 hours post ingestion. During this crucial period, symptoms are typically non-specific, mild, or may even be entirely absent. This can unfortunately delay the recognition of the overdose. Patient might experience anorexia, a loss of appetite, malaise, a general feeling of discomfort or unease, diaphoresis or excessive sweating, nausea and vomiting, which are common but easily mistaken for other gastrointestinal disturbances, and potentially mild abdominal pain. The deceptive nature of this stage underscores the importance of thorough history. Stage 2, the latent phase, spans 18 to 72 hours post ingestion. This stage is characterized by a deceptive improvement in the patient's general condition as initial gastrointestinal symptoms may resolve. However, this is a critical period where underlying liver damage silently progresses. Key indicators, if present, might include right upper quadrant abdominal pain and tenderness as the liver begins to swell and become inflamed. Hypotension, a drop in blood pressure, could signify a more severe systemic effect. Crucially, while the patient may appear better, laboratory tests which will be discussed will likely show initial elevation in liver enzymes, signaling the ongoing damage. Stage 3, hepatic injury and failure, occurring between 72 to 96 hours post ingestion, is the most critical phase. Here, overt signs of liver failure become dramatically evident. The clinical presentation is severe and includes jaundice, the yellowish of the skin and eyes due to bilirubin accumulation, indicating severe liver dysfunction. Coagulopathy or impaired blood clotting results from the damaged liver's reduced synthesis of clotting factors, leading to easy bruising or bleeding. Hepatic encephalopathy, brain dysfunction caused by the liver's inability to remove toxins from the blood, manifest as confusion, disorientation, altered consciousness, and potentially coma. Finally, renal failure or acute kidney injury can occur either due to direct toxicity or as part of multi organ failure. Stage 4, beyond the 96 hours, marks the crossroads of recovery or death. If the patient survives the acute liver failure experience in stage 3, recovery of liver function can occur over weeks to months, typically without progressing to chronic liver disease. However, in severe, unmanaged, or late presenting cases, multi organ failure can relentlessly progress, ultimately leading to death. Accurate diagnosis relies on precise criteria. The definition of an overdose varies slightly between adults and children, but consistently centers on the amount ingested. For an acute single overdose in children, this is defined as ingestion of 200 milligrams per kilogram or total of 10 grams, whichever amount is less. In adults, it defined as ingestion of 150 milligrams per kilogram or total of 7.5 to 10 grams within a 24-hour period. A staggered overdose refers to the ingestion of potentially toxic dose over a period exceeding 1 hour, often associated with intestinal self-harm. In such cases, immediate N-acetylcysteine treatment is highly recommended. Repeated supratherapeutic ingestion involves taking doses higher than recommended over a multiple administration, which can also lead to toxicity. This particular scenario can be especially challenging to diagnose as initial symptoms might be mild or non-specific. Finally, if there is suspicion of intestinal overdose or if the exact time or amount of ingestion is unknown or unclear, treatment should be considered based on strong clinical suspicion and subsequent laboratory results. Laboratory tests are indispensable for confirming toxicity, assessing the extent of liver damage, and monitoring prognosis. The single most critical test is the serum paracetamol level. This concentration, measured at specific time points post ingestion, is then plotted on a Rumek Matthew nomogram. This nomogram is a vital tool used to predict the likelihood of hepatotoxicity and to guide the decision for N-acetylcysteine or NAC therapy, particularly for acute single ingestions. Further assessment involves liver function test. Alanine aminotransferase and aspartate aminotransferase are liver enzymes that leak into the bloodstream when liver cells are damaged. Elevated levels indicate hepatocellular injury. In severe toxicity, ALT and AST can rise dramatically, sometimes exceeding 10,000 to 20,000 international unit per liter, with maximum enzyme elevation typically occurring between 72 and 96 hours post ingestion. Elevated total and direct bilirubin levels suggest impaired liver excretion or severe hepatocellular damage. The coagulation profile, specifically the international normalized ratio and prothrombin time, measures how long it takes for blood to clot. A prolonged INR or prothrombin time indicates impaired synthesis of clotting factors by the damaged liver, serving as key indicator of severe liver dysfunction and acute liver failure. Renal function tests such as creatinine and blood urea nitrogen measures kidney function. Acute kidney injury can occur in severe paracetamol toxicity either in isolation or more commonly alongside liver failure. Electrolytes and glucose levels are also monitored to detect metabolic disturbances such as hypoglycemia, which can be complication of severe liver failure. Effective management is a time-sensitive and a multi-pronged aiming to prevent further absorption, neutralize the toxic metabolite, and support vital organ function. Gastric decontamination, primarily with activated charcoal, is a key initial intervention to prevent further paracetamol absorption from the gastrointestinal tract. Activated charcoal is recommended for patients who have acutely ingested a potentially hepatotoxic amount of paracetamol. It is most effective when administered within the 1 to 4 hours post ingestion as it rapidly absorbs paracetamol. Early administration, specifically within 3 hours, has been shown to reduce the need for N-acetylcysteine therapy. For modified release paracetamol, activated charcoal may be administered up to 4 hours post ingestion for significant ingestions greater than or equal to 10 grams or 200 mg per kg, whichever is less. However, activated charcoal has contraindication. It should not be given to patients with an unprotected airway, such as those with altered mental status without intubation due to aspiration risk, or in cases where the patient has ingested substances that AC does not effectively adsorbs. N-acetylcysteine or NAC therapy is the absolute cornerstone of treatment for paracetamol overdose due to its critical role as an antidote. NAC function primarily by replacing the glutathione, acting as precursor to cysteine, which is the rate-limiting step in glutathione synthesis. By restoring glutathione levels, NAC enables the liver to detoxify the harmful NAPQI metabolite. Additionally, NAC helps convert NAPQI back to non-toxic form, act as an antioxidant, and may improve microcirculation within the liver. Its effectiveness is profoundly time-dependent. NAC is nearly 100% effective in preventing hepatotoxicity if administered within 8 hours of an acute paracetamol ingestion. Even if administered later, NAC can still significantly reduce the severity of liver injury and mortality, although its efficacy does decrease within time. Despite delayed treatment, hepatotoxicity and deaths can still occur in severe cases. NAC can be administered intravenously or orally. Intravenous NAC is generally preferred in severe cases for patients who cannot tolerate oral intake or when rapid delivery is needed. The traditional 3-bag IV protocol, which is the FDA approved standard for acute single ingestion, totals 300 milligrams per kilogram over 21 hours. It mimics oral kinetics with the 3 distinct bags. The loading dose bag 1 is 150 milligrams per kg infused over 1 hour, typically a 200 mg per ml NaC concentration in 5% dextrose. The second dose bag 2 is 50 milligrams per kg infused over 4 hours at 100 mg per ml concentration. The maintenance dose bag 3 is 100 mg per kg infused over 16 hours at a 40 mg per ml concentration. For example, for a 17 kg adult, bag 1 will contain 10.5 grams of NaC and 500 ml of 5% dextrose. Bag 2, 3.5 grams in 500 ml and bag 3, 7 grams in 1000 ml. If hepatotoxicity persists, evidenced by elevated ALT or AST or INR greater than 1.5 after 21 hours, maintenance should be continued at 100 milligrams per kg every 12 to 24 hours until resolution. To reduce complexity and errors, simplified protocols have emerged. The SNAP or Scottish and Newcastle Antidote Protocol is a 2-bag IV protocol totaling 300 mg per kg over 12 to 20 hours. It combines the loading and second phases into one bag. The loading initial bag 1 is a 200 mg per kg infused over 4 hours, typically a 6.25 mg per ml NaC concentration in 5% dextrose or normal saline. The maintenance bag 2 is a 100 mg per kg infused over 8 to 16 hours at the same 6.25 mg per ml concentration. For a 70 kg adult, bag 1 will have 14 grams of NaC in 2240 ml of fluid infused at approximately 560 ml per hour. Bag 2, 7 grams in 1120 ml infused at about 70 ml per hour. This can be adapted for a 12-hour total for early presentation or 20-hour version. An emerging one-bag IV protocol set to launch April 2026 in some regions for smart pump equipped facilities automates switching between loading and maintenance phases using a single admixture, offering a total of 300 mg per kg over approximately 21 hours. Oral NaC is another option, though less common due to the risk of vomiting and slower absorption. It is FDA approved and typically involves a total of 1330 milligrams per kilogram over 72 hours. This regimen begins with a loading dose of 140 milligrams per kg orally, followed by a 17 maintenance doses of 70 milligrams per kg every 4 hours. The NaC is often diluted in juice or soda to mask its distinct sulfur taste. For 70 kg adult, this would mean a 9.8 gram loading dose and each maintenance dose being a 4.9 grams. While generally safe, NaC can cause side effects. Anaphylactic reactions are common with intravenous NaC, manifesting as flushing, rash, urticaria, bronchospasm, and hypotension. These are typically infusion rate dependent and manageable by temporarily stopping or slowing the infusion and are distinct from the true anaphylaxis. Gastrointestinal distress, particularly nausea and vomiting, is more common with oral NaC. Crucially, errors in preparing NaC solution have led to iatrogenic overdoses, highlighting the crucial need for careful pharmaceutical preparation and administration. Importantly, NaC is safe and strongly recommended for paracetamol overdose in pregnant individuals, as delaying treatment poses a significant risk to both mother and fetus. Beyond specific antidote therapy, patient with paracetamol overdose requires a comprehensive supportive care, particularly those progressing to liver failure. This includes meticulous fluid and electrolyte management to correct imbalances and maintain hydration. Glucose monitoring and supplementation are vital to prevent or treat hypoglycemia, a common and dangerous complication of severe liver damage. Management of coagulopathy may involve vitamin K administration and fresh frozen plasma for severe bleeding. For hepatic encephalopathy, lactulose and antibiotics like rifaximin may be used to reduce ammonia levels. Monitoring for renal failure is essential as dialysis may be required if severe kidney injury develops. In the most severe cases where irreversible acute liver failure occurs, the liver transplantation may be the only life-saving option. The prognosis for paracetamol overdose is heavily dependent on the timing of intervention. If treatment with NaC is initiated within 8 hours of acute overdose, the prognosis is excellent with liver injury being largely preventable. However, patients presenting later, especially after the onset of liver injury, face a worse prognosis. Factors influencing this prognosis include the total amount ingested, the type of exposure, whether it is an acute single dose or a staggered ingestion, and the elapsed time since exposure. The severity of liver damage indicated by high transaminase levels and prolonged INR serve as a key prognostic marker. The complications of paracetamol overdose are severe. Acute liver failure is the most serious, being the leading cause of acute liver failure in many Western countries and the second most common reason for liver transplantation globally. Acute liver failure is characterized by a severe impairment of liver function leading to coagulopathy and hepatic encephalopathy. Renal failure or acute kidney injury, although hepatotoxicity is the primary concern, can occur in up to 2% of paracetamol overdoses, often coexisting with the liver failure. It is considered an extrahepatic manifestation of toxicity. In the most severe cases, paracetamol toxicity can lead to multi-organ failure, affecting the liver, kidneys, and the central nervous system, ultimately leading to death. Prevention of paracetamol overdose requires a multi-sectoral approach involving public education, packaging regulations, and healthcare provider awareness. Public health recommendations are paramount. Campaigns like the American Liver Foundation's Know Your Dose educate the public on safe acetaminophen use. Key messages include always reading and following medicine labels, being aware of other medicines containing paracetamol to avoid unintentional double dosing, never taking two paracetamol containing medicines simultaneously, and never exceeding the recommended dose. Effective education campaigns are crucial for improving safe use, particularly given paracetamol's common inclusion in numerous over the counter and prescription medications. Continuous education for healthcare providers on current guidelines for diagnosis and management of paracetamol toxicity is also vital. Packaging regulations play a significant role. Regulatory bodies such as Australia's Therapeutic Goods Administration have mandated reduced maximum pack sizes for paracetamol in pharmacies, supermarkets, and convenience stores. This measure aims to limit the quantity available for intentional overdose, which is highest among adolescents and young adults. Blister packaging is increasingly required for all paracetamol tablets and capsules, making it more difficult and time consuming to assess multiple doses, thereby acting as a deterrent for impulsive overdoses. Specific formulations such as individually wrapped powders or sachets of granules are also seeing reduced maximum pack sizes. A multi-sectoral, collaborative, and phased approach led by government, regulatory, and research agencies is strongly recommended to effectively prevent paracetamol overdose. Thank you for your attention to this critical topic. We hope this presentation has provided you with a deeper understanding of paracetamol toxicity. Your commitment to recognizing, managing, and preventing this common yet dangerous overdose is invaluable. Knowledge is our best defense. Stay informed. Like, share, and subscribe to the Docsaab's Diary for more vital health insights. Thank you.